Are we ready to go? Okay, fantastic. We are so lucky tonight to have a highly respected cardiologist. First, I should start off. I'm Jody Wright. I'm the membership director. Nice to see so many familiar faces and some new ones too. Dr. Kapadia was born but not raised in Virginia. I just learned a fun fact about him. He spent most of his formative years in Hong Kong. But did also receive his medical degree from the University of Virginia and then completed his residency in internal medicine at the Medical College of Virginia in Richmond. He currently serves as Chief Medical Officer at Aligned Cardio and cardiologist at James River Cardiology. But before I turn things over to him, we do have a special guest this evening as well, Dr. S. And I'm so embarrassed that I spent a dozen times yesterday trying to get your name right, and I'm gonna butcher it. So will you please say it for the group? Yeah, come on up.
All right. So I am Dr. Senvratna. I'm going to be, yes, you see why we go by Dr. S.
Well, you said it so fast.
Yes. I try to say it fast so that you don't notice when I mess it up. So please feel free to call me Dr. S. That's perfectly fine. But I am planning to start here November 1st, and I'm very excited to work with you guys.
Excellent. So Dr. S is trained in family medicine. He enjoys helping you all with lifestyle medicine, integrative medicine, and he's currently training in functional medicine as well. So sharpening your skills on an ongoing basis. I'm going to continue to try to sharpen mine, better myself, improving, learning your name. We're all here to better ourselves, and Dr. Kapadia is going to help us with that. You might have a chance to say hi to Dr. S. In the meantime, our featured speaker, Dr. Kapadia. Thank you so much for being here.
All right. Well, thank you all for having me and asking me to come and do this talk. I spoke a few years ago here about sort of what's new in cardiology, and this year I thought I would talk a little bit really about early detection prevention, but kind of take the spin on longevity and health span and dive into that a little bit, you know, and heart disease, as you know, is the #1 killer of men and women in the United States, and it doesn't need to be that way. And I'm going to kind of tell you why and how we can kind of fix that problem. So, some of you in this audience, hopefully many of you recognize this gentleman, Tim Russer. He was a Meet the Press host for many years, and he died tragically in 2018 in the NBC studios of a heart attack. And so he actually had evidence of plaque based on a CT heart scan. He had a stress test a couple of months prior to that was normal. And, you know, he was overweight, had high blood pressure, had some risk factors for heart disease, and had a cardiologist. So what went wrong? And we'll kind of explore that, and that ties into the rest of the talk. So 1 in 5 deaths in the United States are caused by heart attacks, heart disease, far outpacing breast cancer. And if you think about women, you know, it's 1 in 10 that get breast cancer, but it's 1 in 3 that are going to get heart disease. So. And as we look at the United States, where we think we have the best healthcare system in the world, we've started to take a little bit of nosedive in our life expectancy, which is kind of tragic. We've got the most expensive healthcare system in the world, but unfortunately, if you look at a lot of healthcare outcomes, we rank really poorly on a lot of them. And so, like, why is that discordance? And I think part of the problem is that we focus on sick care and we focus on the last portion of life and spend a lot of money on that part of it. Not that it's not important, but we don't spend the time on the early part, the early detection prevention part. So if you think this is a graph looking at heart attacks, sudden cardiac death, cardiovascular events overall in American men and women. And if you look at this graph, you can see there's a slanting. As you get older, you have more events, but a full 50% of cardiac events happen below the age of 65. So, and that's kind of where we start thinking about prevention in our 60s and 50s and 60s, and the events are already happening. So there's a discordance there in the way we're thinking about this. And sudden death is the presentation in 50% of these cardiovascular events, heart attacks, whatnot. So that's not good. You have no warning, and the first time you present with heart disease is sudden cardiac death. That's pretty terrible. And survival from sudden cardiac death, is abysmally low. So we need to change the paradigm from what care in the United States is, from reactive, wait till it's broke, kind of cookbook, one size fits all, to where we need to go, this medicine 3.0, which is all the P's here: proactive, preventative, personalized, precision, and participatory. So, and I think that probably embraces what the physicians and providers at Welcome MD are, and that's why you guys are here, is really thinking about using biomarkers, using imaging to be able to get ahead of the game and prevent disease rather than wait till it happens, right? And we know that a lot of the chronic conditions are really driven by a lot of risks and behaviors that ultimately result from sedentary lifestyle, obesity, smoking, poor eating, the standard American diet or the SAD diet, as we were talking about earlier, stress, lots of different things that kind of funnel into what drives 80% of chronic conditions. And that maybe is the price of affluence, or affluenza as I call it, a lot of the diseases of in Western countries that you don't see in underdeveloped countries. Now they have their own issues with malnutrition and starvation and famine, but as we think about life and longevity and mortality, it's really what we want to do is live as long as we can. That's great, and longevity has improved considerably over the past 50 plus years, right, with modern care. People don't die from heart attacks and strokes as nearly as often they do. People don't die from trauma. People don't usually die from infection. Of course, COVID was sort of an aberrancy in that timeline. But if we're thinking about trying to live longer, we also want to live longer with a better quality of life. And that's kind of what health span is, right? We want to live longer, but we want to live it with good quality of life, right? And how do we do that? So we kind of want to keep going and then drop off the cliff. That's kind of where the ideal is, rather than going down this path where you have chronic illness, you're in the hospital in and out, and you end up in a nursing home, and then you die lonely, and that's a terrible way to go, right? So if you could just die in your sleep one day, perfect, right? So that's kind of what we're trying to. That's where we'd love to go, right? Until we can't go anymore. So my talk is sort of inspired by, and it's the practice I've been doing for over 25 years, sort of that early detection prevention, being really proactive. And I'm a big fan of a physician from Austin, Texas named Peter Attia that has written a book called Outlive, talking about longevity and health span, and has a podcast called The Drive that goes into a lot of detail about this. Everything I'm going to talk about today, every topic could be a 2 or 3 hour topic, right? So we're going to kind of, it's kind of this 30,000 foot view. We'll dive deep a little bit and then we'll come back out. But there's a lot of these topics we could double click on and get into really deep. And maybe that's a subject for another talk down the road as we go down the path here. So if we think about heart disease, cardiovascular disease, there's a lot of things that drive to that. And we're going to talk about, what am I talking about in terms of cardiovascular disease? But diabetes, cholesterol, blood pressure, sleep apnea, chronic kidney disease, a lot of things that end up causing plaque. And specifically, what are we talking about? So the heart is a phenomenal organ. You guys have had talk about imaging probably earlier this year. But the heart, beats 100,000 times a day, pumps 1.5 gallons of blood every minute, every hour, and it is does all this through about 60,000 miles of blood vessels. That's going around the earth twice. So that's pretty phenomenal. These blood vessels that we have, are not like inert pipes. They contract and they relax, and they have a lining that should be like Teflon. Nothing should stick to them. But unfortunately, things happen early on in life that cause damage to the endothelium, which is the lining of the artery. And then if you have too much cholesterol and the wrong kind, it starts to get trapped inside the inner layer, and inflammation happens, and that's the genesis of plaque in the arteries. So that's what we call ASCVD, or atherosclerotic cardiovascular disease. And this is sort of the progression. It starts from normal, and then you cholesterol gets in the layer of the lining of the arteries, starts getting inflamed and oxidized, and you start to get plaque. And the evolution of plaque is either going to manifest as narrowing, eventually causing restriction of blood flow, and that would require a stent or a bypass and cause symptoms like chest pain or shortness of breath, or it could result in this fatty plaque right here that suddenly gets inflamed and ruptures, and that cholesterol gets exposed to flowing blood that creates an injury response, and platelets, which are blood elements involved in clotting, suddenly get in and cause, actually that's a good example of a plaque rupture right there, that cause clots to form. And when you're talking about a 3 or 4 millimeter vessel, that's a clot, and you have 100% blockage when there was maybe 20-30% plaque prior to that. So that's a heart attack or a stroke in evolution, and that's a 911 event. So we don't want either of these scenarios playing out. So from an imaging standpoint, I'm going to quickly go through ways to detect plaque in the arteries. So one of the things that I refer patients out that are at risk for heart disease is doing a calcium score, looking for calcium deposits in the arteries. So as plaque matures, eventually it calcifies as it heals, and you can detect that on a CT scan showing calcification in the arteries. And so calcium deposits equal plaque, and this is a really good, easy way to screen for coronary artery disease, or ASCVD. It's non-invasive, low radiation, it's pretty fast. It's $130, and various places around Richmond do this. You can get even fancier and inject dye, and you probably heard about the Clearly test or CT angiogram, where you can inject dye and look at the arteries and look for soft plaque too, which is a really cool thing. This is not always covered by insurance, and it usually will cost $1,300 to $1,500, but it can give you a ton of information. If there is evidence that you do have a critical blockage based on a number of tests, you can do an angiogram or a heart catheterization either through the wrist artery or through the groin, and you can see a severe blockage in the right coronary artery here that would need fixing. And then there's non-invasive ways to look at blood flow, a physiologic test that we do in our office called a cardiac PET scan that looks at blood flow during stress and rest, and you can see there's this is sort of like donuts and horseshoes, and what you should see in this part of the horseshoe, there's decreased flow, and it normalizes here. So it's a good example of someone that has a severe blockage in this part of the artery that should then have an angiogram to sort out stuff. But as we dive deeper into the labs, and that's the other part of the equation, is how can we tell from blood tests? Cheap, relatively cheap, easy. We can get a lot of information. So cholesterol. We think cholesterol is a bad word, right? We can't live without cholesterol. Cholesterol is part of our cell membranes. Cholesterol is part of various hormones, sex hormones, estrogen, testosterone, cortisol, vitamin D. We couldn't live without cholesterol. And honestly, only about 15% of cholesterol hangs out in the bloodstream, and that's what everyone gets really excited about, is that cholesterol. So there is no such thing as good or bad cholesterol, honestly, and I'll explain that in a minute. The liver every cell makes cholesterol. The liver makes the most, and cholesterol can't float freely in the blood. It's like oil in water. So what ends up happening is that the liver creates these transport vehicles called lipoproteins. And lipoproteins basically contain varying amounts of cholesterol and triglycerides, which is a marker of fat, if you will, and transports them around to the various organs. So we have two families of lipoproteins, the family of apolipoprotein B and ApoA. And ApoB is really what we want to focus on, because that is if you have too much of ApoB, that's what causes plaque in the artery. So ApoB, these are the key cholesterol numbers for you to know. ApoB, non-HDL cholesterol, which is simply total cholesterol minus the HDL, the quote-unquote good cholesterol. Your LDL cholesterol is usually a calculated number. Sometimes you can measure it directly. Triglycerides, and something called Lp(a). We'll talk about that more. So this is a picture of the lipoproteins looking at density and diameter. And so the HDL is in a family of proteins that are quote-unquote good, and that's apolipoprotein A, and then the rest of these are ApoB lipoproteins. They're all tagged with an ApoB protein, and there's a whole family of them, and varying in density and size, and you can measure all of these in a regular cholesterol kind of panel. So this is ApoB. And ApoB honestly is one of the most important numbers that most other physicians don't even measure in a regular cholesterol panel in the United States. In Europe and Canada, a lot of them do, but in the United States it's not even part of our guidelines. So ApoB is really important. So think about it. ApoB is the protein, and inside is all this fat. It's cholesterol, triglycerides, and each of these different types of lipoproteins, VLDL, IDL, LDL, have varying amounts of cholesterol and triglycerides that determine their density and whatnot. When we're looking, these guys don't hang out in the bloodstream very long, so most of the time what we're measuring is LDL cholesterol. But you have a lot of these guys if you have prediabetes, diabetes type of scenarios. And so this becomes really important as we start to think, when you look at a cholesterol panel and you look at a patient that has an LDL cholesterol of 100, and you have two patients that have the same level of LDL cholesterol, but they may be very different in terms of how many cholesterol particles they actually have. So you can actually measure the number of cholesterol particles or number of ApoB particles and the size of these particles. So the smaller the particle size, the more atherogenic, more likely they're going to cause plaque in the arteries. The bigger, the more fluffy, the more benign they are, right? So if you're looking at, when you do an LDL concentration on a blood panel, you're just looking at the concentration of cholesterol in the blood. You don't have any idea how many particles or what kind of particles you have. So the same person could have a lot of small particles, and that person is much more at risk for developing plaque or having ASCVD compared to the person that has larger particles. So just looking at the LDL concentration doesn't give you enough information. So that's why you need a more advanced panel. So here's an example of a cholesterol profile. LDL of 100, triglycerides of 168. Now, to my eye, when I see a triglycerides of 168, that's a marker of carbohydrate sensitivity. And that's the main reason you get your cholesterol test fasting, because that can be really impacted by what you just ate. LDL much less so. So my ideal triglycerides is less than 80. Less than 100 is good, but less than 80 is even better. So this person has more than double. And so I already know by looking at this person is probably insulin resistant. They probably have a lot of small LDL cholesterol. So if we did another panel and we look at ApoB and LDL particle number, they're kind of the same thing. You can see that this patient has a ton of elevated ApoB and LDLP, and there tend to be small size particles. And so on this panel, everything looks red where they were yellow and green on this panel. And so this gives you a lot of information to talk about with the patient with respect to cardiovascular risk. And they also have this elevated LP little a. Stay tuned for more on that. So when we look at studies, we can tell that just measuring LDL concentration usually is okay, except when we think about the US population where 2/3 are overweight and obese, and diabetes, prediabetes is a big part of that. There's a lot of discordance between LDL particle number and LDL concentration. And that really becomes true. And the thing that really trumps sort of your risk prediction is LDL particle number. So when I think about on a blood panel, what would be my preference in terms of data? It would be ApoB, or LDL particle number, then non-HDL, and then LDL-C, right? So in terms of, so I really feel like in my panel with patients, I check an ApoB with every visit, right? I'll check the usual panel, but an ApoB with every visit, because that is the best indicator of your high-risk cholesterol status, if you will. Now, what else could go wrong? Well, there are patients that have genetically high cholesterol, like really high cholesterol. Their LDL concentrations are over 190, 200, and these typically are associated with very earlier onset heart disease in their 30s, 40s, and it depends on whether you have one gene that's abnormal or two genes that are abnormal. Folks that have two genes that are abnormal often will die in their 20s. And then the heterozygous, which is far more common, and we see that are associated with high cholesterol. So that's one thing that could go wrong. Anyone recognize this guy? Biggest Loser, Bob Harper. Picture fitness, right? Had cardiac arrest, like Tim Russer, but survived it, and he was very fit, right? I mean, so different kind of fitness. So he had a genetic marker called LP(a) that was elevated. We talked about LP a little bit. So what this is a genetically mutant LDL particle, and there is another protein called ApoA, that binds to ApoB and makes it much more atherogenic. So atherogenic means causing more plaque in the arteries. Okay, so that's why I'll use that word, frequently. So it makes it more atherogenic, and it increases the risk of clotting, blood clotting. So there's a higher risk of heart attack and stroke in patients with elevated LP(a). So 20% of the population has LP(a). It tends to be highest in African ancestry, then South Asians are probably the next, and it's an independent ASCVD risk factor. Nothing we can do with diet, exercise, lifestyle is going to lower LP(a). There are certain medications that can lower it, and there are actually 3 or 4 different drugs in clinical trials right now that are quite promising that are specifically looking at lowering LP(a). Everyone should have LP(a) measured once, right? And as part of their risk assessment. It's such an important thing to check, because even if you can't lower LPA directly, what you should do is lower everything else. Lower your ApoB, lower your triglycerides, work on all the risk factors you can with diet, exercise, and medication. And we'll get to medication at the end. Hopefully we'll have time to do that. What's the other piece of the puzzle? It's inflammation. We talked about that, right? So we talked about lipoproteins. Something has to cause injury to the Teflon lining of the arteries. High blood pressure, smoking, diabetes can do that. And then there's inflammation, right? So we measure inflammatory markers in our blood panel, CRP, C-reactive protein, non-specific marker of inflammation. Anything can make CRP go up, fever, injury, any kind of inflammation. And then LP, PLA2, and MPO, these are more blood vessel specific markers. Checking an A1C is really important, right? Because diabetes, prediabetes, homocysteine is an amino acid when in high levels can also be associated with accelerated ASCVD, and then uric acid, gout, is also a signal for metabolic derangement. So these are important numbers to check in a panel, at least baseline. So we think about the other piece here, we were talking about A1C, is insulin resistance for prediabetes. And this is a big problem, right? I mean, we've seen, the diet recommendations that we had 30, 40 years ago was decrease saturated fat. That was the American Heart Association, by the way, that said decrease saturated fat, and that was the culprit. What happened is that the fattening of America, so people ate more carbs. And sadly, a lot of the sugar data was suppressed and didn't come out, and so we started having these chronic pandemics of diabetes and obesity. And so this doesn't need to be, this is really a symptom of modern living, because as hunter-gatherers, we didn't have an abundance of food. Now we eat 24/7, have so much abundance, and so our biochemistry has not evolved to really adapt to so many calories. We're sort of being overnourished. And so as a result, the body stores it. And the muscle, the fat, and the liver are sort of the target organs. When we eat carbs, insulin goes up to help drive the excess glucose in the blood into these different organs. And as we start to consume more calories, these tissues, the liver, the muscle, the fat, become resistant to the insulin, and so glucose eventually goes up. The pancreas tries its best, but by the time you become a diabetic, you've lost 80% of that pancreatic function in terms of insulin production. So that's the bad news. The good news is you can get way upstream from that and cure the problem. It's completely reversible. Well, we can talk about diabetes, so I don't want to spend too much time there. Those are definitions of diabetes. Okay, so here are so I'm a big fan of, I think that there is a role for medications, and we'll get to that at the end, but the pillars, the foundation of treatment is really diet and lifestyle, right? And so nutrition, sleep, well-being, and exercise, in no particular order there, but we'll go through all of them. That's really the key to health span and longevity. And it can start ideally it should start from our childhood, but it's never too late to kind of take control and make changes when needed. So Peter Attia, who I mentioned earlier, said we're all overnourished, right? The standard American diet, the SAD diet, and the problem we suffer is really from excess calories, too much energy we're consuming, and we're not burning enough energy. This is kind of really a picture of what we should be eating. Lots of colors, straight from the ground, that type of thing. But it's not what we're eating day to day. So food interventions, how can we think about, and I really hate the term diet. I hate all the different diets that are out there because I feel like they're short acting and they're prone to failure. And most any type of diet involves restricting calories. And so you can lose weight for 3 to 6 months very easily by just restricting calories, right? You can restrict the kinds of macronutrients you eat, less carbs. You can time restrict, what's known as intermittent fasting. You can cut back the time that you actually eat and your feeding time, your feeding interval, from 12 hours to 18 hours to 20 hours of fasting, and eat in a smaller period. So by definition, you're going to consume less calories. Or you can just decrease the amount of calories you consume on a daily basis. And all those ways will lead to loss of weight. And not everyone responds the same way. Sometimes it's a hybrid of these techniques. So these are food tactics that I think about, right? First, the highest order is to reduce calories, reduce consumption of food. We all think we eat less than we do. We all think we move more than we do. So cut the junk, right? First step is processed food, bad. We can't get away from it. But the less junk food, processed food that we eat, and that's all the stuff in the grocery store that's in the middle, in contrast to the fresh food on the sides, that's better. Getting more protein, and we'll kind of get into that in a little bit, but the recommendations for protein intake are woefully inadequate because as we age, we lose muscle mass, and eating more protein is really, really important, whether it's plant-based, animal-based, however you think about it. Thinking about a continuous glucose monitor. Have any of you seen a CGM? It's those things, yeah, see, you can actually check your sugar in real time. They work really well. They're only covered for patients with type 2 diabetes at this point by insurance, but you can get them, at for out-of-pocket cost. And they're very helpful to really understand when you eat certain things, how your body reacts to it by measuring it. And you only have to do it for a few months, and then you have a lot of good data about your own personal eating habits. And then drink less alcohol. So the whole idea that red wine is better for you than other alcohols, it's all a myth. I mean, alcohol at the end of the day has no nutritional or health benefit, right? But a little bit in social occasions is good. It's a social lubricant. It's fine. It helps with that social connection. No issue with that. But if you drink more, then there's really liver and brain and all those kinds of things. So that's the food part of it, right? And that's a whole nother topic that we could dive into. I know you talked about it at a previous talk, and there's a lot more details on that. And then sleep. Right, we were trying to be macho about sleep. I only slept 4 hours, and I'm, in residency. That's kind of how we survived. And honestly, we can't do without sleep. If there's one thing that we cannot do without in any of these things is sleep. And we really need at least 7.5 hours to 8 hours of sleep every night. And if we don't get it, it can lead to activation of stress hormones. It leads to more neurodegenerative memory problems. A whole host of things. So sleep is vital to regeneration. It's vital to so many things. So getting adequate sleep. Now there's a subset called sleep apnea that a substantial number of people have, and that's when people snore and stop breathing for periods of time, and using the CPAP or a dental appliance can be really helpful in that situation. But there are a lot of people that just suffer from insomnia, whether they can't fall asleep or they have trouble staying asleep. And there's a lot of tactics around that, right? And establishing a really good bedtime ritual is super helpful. So that's a whole nother talk, but I just want to highlight that that's an important pillar that we don't want to forget. That if we don't lock in the sleep piece, then it's really hard to figure other stuff out. Okay. So this is really a slide about, emotional well-being and really thinking about stress, anxiety, depression, and that's the other piece, right? I mean, it would be terrible to live a long life and be really unhappy. And so we know in tangible and intangible ways that your emotional well-being is super important to your physical health. And we know that mind-body connection. And so recognizing depression, treating depression however we need to treat it, anxiety is super important because it ties into everything else. And at the end of the day, inflammation, stress hormones, blood pressure, all these different illnesses that manifest not only cardiovascular, but cancer, neurodegenerative disease, diabetes, can all be influenced by your state of mind. And the last piece here is really looking at exercise, and I'm going to dive a little deeper here. So for those that can't see this little cartoon, it says, what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? So exercise is something we just don't pay enough, and it to me is the top here. I put it at the end because I wanted to talk about it a lot more, but it is probably the most important thing. Right, and when I think about exercise, I think about these 4 things. Stability, which means that's the foundation of exercise. It's really about, you want to do things and exert force and move, but you don't want injury, right? You don't want to suddenly go to the gym and start lifting heavy weights and then get injured, or run and get injured. And stability is probably the most important foundation upon which cardio and strength training kind of fit. So stability is you can think about it as flexibility, you can think about coordination, you can think about it as core work. There's a lot of aspects to that. And core work, by the way, is not just about your abs, so it's a lot deeper than that. Strength work, aerobic efficiency, that's your general cardio, and then thinking about peak aerobic output, like what can you really sustain in a high intensity kind of workout. So if we look at this, we know that exercise has this dramatic ability to reduce death and increase longevity, and you don't have to do very much to move the needle, believe it or not. So if you did 150 minutes a week of physical activity, moderate, vigorous, you look at the slope starts to drop dramatically, and there's benefit all the way out, but that's the biggest bang for your buck, right? So just moving some can make a big difference. Going for a walk. There's a concept here called VO2 max. Have any of you heard of that before? So it's your maximal oxygen consumption. So it's the ability of your engine, your heart, to be able to deliver fuel to your muscles and your vital organs when you really need it in a high intensity way. And this is a marker of, one of the two markers in exercise. This is one marker that predicts longevity more than anything else. It's probably more than any medical intervention that we can see out there is measuring your VO2 max. And this is done either on a treadmill or on a bike, where they put an oxygen mask and measure your oxygen and carbon dioxide and come up with a number. And so it's a really important number that's measured in milliliters per kilogram per minute. So if we look at, VO2 max in terms of activity, it drops dramatically as we age. With every decade, the VO2 max goes down. And, this is something, so as we start to go down in our 60s and 70s, and VO2 max drops literally, by the time we hit our 30s, and starts to decline in all these different activities, even in the elite folks. So what we want to do is to start training now, right? To start training to prevent or mitigate the decline in VO2 max. And why is that important? Because if we look at this curve, the people that are sort of low performance, low VO2 max folks compared to everyone else, there's a dramatic difference. Just getting to below average in terms of exercise performance reduces your mortality by 50%. So if you're a sedentary person and you start moving, you're going to increase survival dramatically. And then there's just upside from there, right? So, and it doesn't have to be, you don't have to be an Olympic athlete. You don't have to be an elite athlete. You can start moving. So there is benefit there. And then there's continued benefit as we move forward, right? So this, and this slide kind of really, so this was a study looking at folks relate to extreme fitness. So people that were, the highest fitness had the lowest mortality. And as you start to be less fit, there was a fourfold higher risk of dying in this situation. And that was compared with the risk of having diabetes or smoking or chronic kidney disease, which we know are force multipliers in terms of morbidity and mortality of dying. But exercise, the less you exercise, and that probably is also, if someone doesn't do a whole lot, they probably have a whole lot of other things going on with them. But that was really intriguing, that compared to the elite or fit or moderate, the folks that exercise the least had a four times risk of dying. So that's really interesting, is that we could mitigate the effects, even if we have some of these chronic conditions, by exercising regularly and vigorously. We can mitigate the effects and maybe even reverse the effects of these other diseases, or at least silence them. So VO2 max is sort of like this high intensity interval workout, right? We want to have bursts of high energy during our activity. But there is a foundation of aerobic activity that's really important. That's called zone 2 training. So VO2 max or high intensity you can call zone 5. Zone 2 is kind of defined by, hey, this is I can exercise for hours. I can talk. Maybe I don't want to talk, but I can talk for a while, and that is kind of zone 2, right? It could be on a bike, could be on a treadmill, could be on a rower, you could be swimming, you could be doing a brisk walk, and you know your heart rate's up, you're sweating a bit. That's kind of zone 2. And if you do zone 2, 80%, if 80% of your cardio workout during the week is zone 2 and 20% is your high intensity VO2 max, that's really a good recipe for the cardiovascular piece of, you know, improving your health span and longevity. And the key here is, this is the mitochondria. So this is the powerhouse of the cell. And the more you do zone 2 training, the more you increase your mitochondria. Why are mitochondria important? Because it comes down to an energy unit called ATP. So as we exert energy, ATP is the energy unit that converts glucose and fat into fuel. And the mitochondria are extremely good at converting fat into fuel. And so doing zone 2 results in efficient fat burning. The more zone 2 training you do, the more mitochondria you have. And it not only helps your cardiovascular health, but there's data that it improves your brain health, right? It improves cerebral blood flow. And all of these things. So however you do it, you know, 1 hour, 30 minutes to an hour, 3 or 4 times a week of some sort of cardio activity. So it doesn't have to be an all-out sprint every time you go to the gym. This zone 2 stuff works, and if you do it for, you know, 30 to 60 minutes several times a week, it can really help a lot in terms of cardiovascular and other kinds of health. So that's zone 2. Now zone 2 is measured by this, what they call rate of perceived exertion, and whatever that amount of exercise, conversational pace, a little, whatever your heart rate is at that point is the right way. So I never guide people like, okay, you should target your heart rate 220 minus age and take 85% of that. I don't really buy into that because everyone's heart rate response with exercise is different. So it's really about rate of perceived exertion, and whatever your heart rate is at that time is kind of your target. And as you exercise more, your heart rate response is going to drop, right? Your heart rate's going to come down because you're becoming more efficient from a cardiac standpoint. And over time, your resting heart rate will drop. Your acceleration with exercise is going to be less pronounced, and then your heart rate recovery, when you do recover, is going to be faster, and that's a good sign of fitness and conditioning. What's the other piece that really predicts longevity? What's the other biomarker, right? We're all looking for ways to measure our baseline and where we are in the spectrum of health and fitness. And so the other is strength, and so believe it or not, grip strength, how well you can grip is a really interesting marker, and there's been a lot of studies on this. So grip strength independently is a marker of health span and longevity in older adults, in everyone. So why does that matter? So from a functional standpoint, can you open that jar, right? But it's not only about your hand, it's an integrated thing that really reflects your strength of your arm, your overall muscle mass and your muscle strength, your bone strength, your nutrition state. So there's a lot of features that go, or a lot of things that go into grip strength. Similarly, VO2 max, you can't hack VO2 max. There's no app that's going to help you drive your VO2 max up. It's hard work, and it reflects lots of time over effort. So both of these, grip strength, VO2 max, are ways to drive better health, and they're really markers of your body composition, of your muscle strength, your muscle mass. So that's really important. If I think about strength, it's, you know, a good example, and a lot of this is about functional stuff. As you think about, what is it that I want to do in my older years, right? If you're in your 30s and 40s or 50s and you like hiking, you know, what do I want to do in my 70s or 80s? Maybe it's not hiking, but maybe it's want to sit on the floor and play with my grandchildren. Maybe it's to go on a long walk. You know, whatever it is that you desire to do, you have to think about, how do I reverse engineer that, and what do I need to do today to ensure that I can do those things tomorrow, right? And so stability, cardio, strength training, because as we grow older, our muscle mass goes down, but not only our muscle mass goes down, our strength goes down, and our power decreases. Power is sort of as we move, and it's a strength over time and speed, how quickly we can do things. So muscle is really, really important. Why is muscle important? Also because it's attached to bone through ligaments and tendons, and that also can improve bone density as well. So one of the things that happens as we get older is our bone density goes down, we get osteoporosis, and if we fall and we're not stable, that can result in a fracture. And hip fractures are often the beginning of the end, right? So trying to avoid that by increasing your bone density. And so you don't necessarily, I think the first order is really working on strength training. Second is consuming more protein to serve your muscle. And then you might need, if you're a woman, to be on estrogen, and you may need to be on osteoporosis drug. But that's not how it would lead, at least on the osteoporosis drug side. So strength, CardioMax, all that stuff is really important. So in the last bit here, I'll just kind of quickly go through pharmacology. So even if you do all the right things, right? If you're exercising, you're eating well, you're sleeping well, you still could have excess risk, and it may be genetic. It could just be, that's just what it is. So sometimes we need to use drugs. And I always find it interesting that many of my patients walk in with a full bag of supplements, but are not willing to take medications. And the problem is I'm not against supplements. I think in a very focused, directed way, if you measure something and taking a supplement and remeasure, great. Vitamin D, that's a good example of that. B12, those type of things. But the problem with supplements, it's a multi-billion-dollar industry. We have no idea what the fillers are, what the ingredients are. It's completely unregulated, in contrast to prescribed drugs. Not saying that there's a problem between generics and brand drugs. Yeah, there's issues there too, but there's a lot more regulation around that. So sometimes taking medications can be an important thing. The first step here is, if your cholesterol is really high, you might need to be on a cholesterol medicine. The first line of defense is a statin drug. And I know there's a lot of about statins in terms of cognitive dysfunction or muscle aches or liver. And honestly, they're probably the most studied drug, in our generation, and they're pretty darn safe if they're prescribed properly. So what can happen? They can cause joint and muscle pain in about 10% or less than 10% of folks. Rhabdomyolysis, actual muscle inflammation, is really rare. Liver toxicity is really infrequent. Diabetes is a real thing, but usually people that develop elevated sugar A1Cs on a statin are patients that are already on their way to developing that. It just accelerates that process. Not a reason not to use it. So what do I do? So in my patients, I usually use, rosuvastatin or Crestor, and I usually use low doses, 5 to 10 milligrams of that. There's another one called pitavastatin, which we can use for people that are truly statin intolerant, that have aches and pains. I often use CoQ10 to supplement with the rosuvastatin to mitigate some of the aches and pains, because CoQ10 in the mitochondria gets depleted when statins are on board, so supplementing. So that's one supplement that I do use and can be helpful. There's a drug called ezetimibe or Zetia that binds to cholesterol in the gut and can be complementary to a statin and reduce the cholesterol by another 20-25%. There's another drug called Nexletol or Nexlizet that works on cholesterol synthesis, so that could be another option. It's a pill. It's newer to the game, so we don't know enough about it yet, but seems to be pretty safe. And then there's these new class of drugs called PCSK9 inhibitors, or these injectable drugs. And as we think about mechanism of action of these newer molecules, they're really interesting. They're like probably the wrong analogy at this time, but they're like guided missiles that do their job, have very little collateral damage, and do what we need to do. So one of them is Repatha or Palliant. They actually decrease cholesterol by 40 or 50%, and they're really well tolerated. You inject them every 2 weeks under the skin with a pen. And then there's another drug called Leqvio by Novartis. That's a drug that we inject as healthcare professionals every 6 months, and that can also work to reduce cholesterol So we have a lot of tools in our toolbox, which we didn't have, 5-10 years ago, which is really awesome. I don't want to get too technical on this one. So in summary, I think if we think about atherosclerotic cardiovascular disease remains the #1 killer in men and women, but it doesn't need to be, right? It can be obliterated. And if we treat it early and aggressively, we can really obliterate this disease. And it really is about lifetime exposure to high levels of cholesterol, right? Remember I said that people often die in their 50s and 60s as their first cardiovascular event. So this process has been going on in their 20s and 30s, and we know from Vietnam vets and car accident victims that cholesterol buildup in the arteries can start in our 20s and 30s. So if we start earlier and identify folks and start to treat aggressively, doesn't mean they need to all be on medications, but recognize that we could make a difference. ApoB is the best target for treatment. So if your doctor doesn't check ApoB, and I'm sure all your doctors do, then make sure you demand it. The goal should be really low. Like when we're born, our ApoB levels are 30, 40, right? And there's really no too low level because every cell makes what they need, the brain makes what it needs. And if you think about infants with low ApoBs, that's a maximum time of brain development, so they're doing just fine. So getting the ApoB super low is important. Lp(a), that genetic marker, should be measured 1 time, and then treat other factors really aggressively. Exercise is perhaps the most powerful force, I believe, more than any other therapy to extend health span and longevity. And measuring VO2 max and grip strength is one way to kind of benchmark and then to measure in a serial way. And of course, nutrition, sleep, and emotional well-being play foundational roles. So I like to think about exercise is, you don't have to be an elite athlete. You don't have to be competing for the Olympics. You can just be training for life, right? Incorporating exercise, strength training, cardio, eating right, working on all these different pillars can really make a big difference in now, but also in the future to help you live better and healthier and happier. So thank you so much. Questions? I'm sure there are.
I didn't see a atorvastatin on your go-to drug.
Yeah, so atorvastatin is one of them. It's not my favorite drug, but practitioners use it. So probably the 2 most common are rosuvastatin and atorvastatin that are used.
Can you
Yes.
comment on resting heart rate?
Resting heart rate?
Yeah, heart rate.
Yeah, so everyone's heart rate, resting heart rate is really a kind of a good, it depends on when you measure it, right? Is it when you're sleeping? Is it when you're sitting around? Is it when you're stressed? But it's a really good marker of your sympathetic nervous system, right? You have your autonomic, you have your parasympathetic, which is your rest and relax, and then you have your sympathetic, which is your fight or flight. And so many of us are in the modern world in fight or flight mode, and so our resting heart rate tends to be up, and that's a measure of cortisol and adrenaline and all of that. The more fit you are, the lower your heart rate generally is going to be, right? Because it's a measure of efficiency. But low heart rate can also be indicative of electrical problems with your heart. Some people, may have slow heart rates, not because they're elite athletes, but because their electrical system is starting to degenerate, and they may need a pacemaker in that situation. And of course, there's medications that you might be on to lower the heart rate, like beta blockers or calcium blockers like diltiazem or verapamil or digoxin even. So that also needs to be, influenced. And then there's something called heart rate variability, because just to kind of expand on that. So, as we look at our heart rate throughout the day, every beat, it's not like a metronome that every beat is exactly followed by the next beat. There is variability, and that variability also is a marker of the health of your sympathetic nervous system. So yeah, that's called HRV. So probably answered more than you need, but
well-being. What about, are there studies or indications of things like yoga, meditation, practicing faith that affect well-being
Yes.
in a very positive.
Absolutely, and I didn't expand on that because I think it's kind of, I could talk all day, but I'm a big fan of all that, and there is good data that being connected, right? If you look at blue zone populations around the country that have incredible longevity, part of their common thread is that level of connection, and so connection leads to good well-being, but then sort of your individual sort of mindset and attitude is really important. And so yoga, as I think about it, not so much from an exercise perspective, but more of a spiritual breath work type of thing, really, really important. Meditation is, again, the next level beyond yoga, and faith has incredible benefit, right? Not only in your own faith, but prayer. So there's a lot of good data showing benefit in all those arenas. What else? Yes, sir.
Two questions. One is, can you speak a little bit more about the Nexlizet versus
Yes.
statins and kind of the mechanism and kind of pros and cons of those in a way? And my understanding is Nexlizet requires you to have gone through, insurance will require you to go through kind of certain hoops. So that's one question. And then the second is around insulin resistance and outside of fasting glucose and HbA1c, like oral glucose tolerance test. Do you have a point of view on like using that to look at?
Yeah, no, great questions. So on the Nexlizet side, newer drug, it works. So statins work on reducing production of cholesterol in the liver. That's how they work. They work in other cells too, and sometimes that's probably why you have the muscle pains. But they reduce production of cholesterol in the liver predominantly by their cells. Nexlizet, Nexletol. So Nexletol is one medicine. Nexlizet is just combined with ezetimibe or Zetia. It works by inhibiting cholesterol production upstream from where statins work. So they kind of mechanistically work in similar ways. Nexletol just works primarily in the liver, so that's really its only effect. Its reduction in cholesterol by itself is not as pronounced as statins. I'm not sure exactly why. Statins, you can get anywhere from 30 to 40% reduction, probably 20 to 30% reduction with Nexletol. So it's a really good tool in our toolbox. There was just one study that came out that showed cardiovascular benefit. So it doesn't have the decades and years of evidence that statins do. Having said that, it's a good drug, but the insurance game is such that you got to go through the game. You got to do the statins. Either you got to fail the statin, meaning you don't tolerate it, or your numbers are not at goal despite statins, and then you pick another tool to use in that toolbox. So it's a great tool that I think that has benefit. To your question about diagnosing insulin resistance, and I think the oral glucose tolerance test is a great tool. Either that or the CGM, right? So I think both of those, A1C can be spuriously low because it's really measuring glucose binding to red blood cells, and the life of a red blood cell is about 90 days. If you're anemic or if you have other issues, that may not be terribly helpful in that situation. So A1C has its downsides. So I agree that if you really want to, and they do that in pregnant women, right? They do an OGTT, an oral glucose tolerance test. You drink 75 grams of sugar, and then you measure your sugar after that. So it is probably the most sensitive way to diagnose it. It just requires work, and it's a difficult workflow. I think the CGM is a really good tool now, and I haven't gotten one yet, but I've thought about it to kind of really see, because you think that certain foods don't have the glycemic load that they do, and then you do a CGM, you measure your sugar, and you're like, oh, wow, that's how my body's responding to this. And so you can really have some great insights in nutritional. So you have an upfront cost if you're not diabetic, but it might be well worth it to really kind of figure out how to modify your program.
So you said sugar is a problem. So soda, if you go diet, is that better?
No. So I think the body is fooled with artificial sweeteners, and so the insulin response is very similar. So I've seen folks that I tell them, stop the diet sodas, and their weight goes way down, and things get better. So, you know, can we get away from artificial sweeteners? I don't think we can. Is there one better than other? You know, stevia, monk fruit versus some of these others. I don't know what the answer is there. I think we just need to consume less of all of that stuff. That's my thought.
Does that include the sparkling water? Flavored sparkling water?
Is there any downside to it?
Yeah.
Yeah.
You mean the carbon? So it really comes down to carbonation, and I'm not aware. You know, I'm not sure that nature intended us to carbonate our fluids. So, and I don't know if anyone else. I don't know if there's any actual evidence that it has downside, but it is fluids. It's not calories, and so if it's a way to consume water and some water, it's good. I still think regular water is better. Europeans love their sparkling water. So I don't know if anyone else has a view on that.
No, but acid reflux sometimes.
Reflux? Yeah, you get a lot of air, yeah. Yeah. Yes,
One
ma'am.
more question. You were
Of
talking
course.
about some people need diagnostics earlier.
Mm-hmm.
Is that driven by your grandparents' health outcomes? Because sometimes your parents, when you're in your 20s or 30s, haven't quite gotten to that 50s, 60s where events
Mm-hmm.
might show up. So what do you recommend for people who might be 20s or 30s that ought to be considering diagnostic?
Yeah, so I think when you think about family history, right, of early disease, you know, if you're really trying to rule out like genetically related stuff, you know, it has to be your parents, your siblings. That's the strongest piece there. Getting, you know, if your grandmother, you know, had a stroke at 90, I'm not sure that that's necessarily relevant, right, to the whole story. So, but if there is something earlier, then that would be something of note, right? Because sometimes things skip generations too, and you know, you're thinking about cardiac conditions like hypertrophic cardiomyopathy. We have unusual thickening of the heart muscle, or cholesterol type of things that we see here. So I think our model probably should be to figure out what are the right biomarkers to test in everyone early on to diagnose things. Now, you know, there are some people in town that are doing whole body MRIs and you know, they're all that kind of stuff. Is that good or bad? Do we go down a rabbit hole? As we know, sometimes that can happen, and where does that stop? And so, you know, on one hand, there is value in checking certain things early on in life, particularly if you have signals from other family members. But it's a fine balance. It really is. And so I don't know if I have the right answer. You know, I think you can tell pretty easily if someone's on a path to cardiovascular disease based on their body habitus, how they look, what their weight is, what their lifestyle is. And, you know, for all my patients that have, you know, obviously I'm seeing patients in their 50s, 60s, 70s, and if they have any markers that are concerning, you know, like the LP(a), I'll do reverse I'll have their kids get their LP(a) checked at an earlier stage. So there are opportunities there.
As far as stress tests, do you see any difference between nuclear and the treadmill?
Yes. So the treadmill test, you know, just with the EKG, you walk on a treadmill, they hook you up with the EKG, by itself has poor sensitivity and specificity. What I mean by that, it's not able to pick up, if it's normal, it doesn't mean you don't have a blockage. And if it's abnormal, that could be a false positive too. And so, you know, it depends on the age group and your pre-test probability, right, of what that. So if it's a 20-year-old with some weird chest pain and they have a normal EKG, you can put them on a treadmill and they're probably going to do fine, and it's unlikely going to be abnormal. But it's someone older in their 40s, 50s, 60s that has some symptoms that are concerning, then doing stress testing with some imaging, whether nuclear or echo, is going to raise the accuracy, the sensitivity of that test significantly. Yes, sir.
What is the best time to take the first statin? Because what is the best time
To take a statin?
Yeah, to take. Is that the best time? The best time?
So So what they say is that the liver makes the most cholesterol at night, and so most of the statins, which are shorter acting, the recommendation is to take them at night in the evening, with the exception of rosuvastatin, which seems to have a longer half-life, and so it doesn't really matter. So that's probably the one exception to the rule of taking it at night. So yeah, so that's the recommendation for anything other than rosuvastatin. Yes.
Have you seen patients that have gotten COVID and had heart problems afterwards?
You know, that's a great question, and you know, I thought I would see a lot, and specific heart problems like AFib, I've seen either from COVID or perhaps related to the vaccine too, in an individual circumstance. But in terms of myocarditis, which is inflammation of the heart, in terms of heart attacks, I've not seen any of that on the outpatient side. Now there are people that are hospitalized with such things, and I haven't seen much of that. What I have seen a lot of in the long COVID folks are people with dysautonomia, or meaning that their autonomic function is just, if you've heard of POTS patients, their heart rate's up, their blood pressure's low, they're dizzy, so they have trouble regulating their blood pressure and heart rate, and that's a really challenging piece. But we've seen a lot of folks that have dysautonomia related to long COVID. Anything else? Any other questions?
Thank
All right.
you very much.
Thank you so much.